Our next paper is entitled Hybrid and Total Endovascular Approaches to Tandem Carotid Artery have similar short and long-term outcomes, to be presented by Dr. Decarlo on behalf of authors from the Massachusetts General Hospital, Dartmouth, and the University of Virginia. Go ahead, Dr. Decarlo.
Hello, my name is Charles Decarlo. I'm from Mass General Hospital, and our presentation is entitled Hybrid and Total Endovascular Approaches to Tandem Carotid Artery Lesions Have Similar Short and Long-Term Outcomes. I have nothing to disclose. Tandem carotid artery lesions that involve simultaneous internal carotid artery and common carotid artery or innominate stenoses are rare, occurring in less than 5% of patients with carotid bifurcation disease. As such, the management of this disease pattern is poorly understood. Described treatment techniques include the hybrid approach, which is a carotid endarterectomy with a retrograde proximal endovascular intervention, and the total endovascular approach, which involves endovascular treatment of both lesions. Recent literature has suggested that both procedures are associated with increased risk compared to the treatment of isolated bifurcation disease alone. However, there is a paucity of data comparing the two procedures. As such, the aim of this study was to compare short and long-term outcomes of the hybrid approach to the total endovascular approach for tandem carotid lesions. We queried VQI data from 2005 to 2020 for carotid stenting and carotid endarterectomy procedures with a proximal endovascular intervention. The following procedures were excluded: emergent procedures, bilateral procedures, procedures with an indication other than atherosclerosis, patients with a prior ipsilateral carotid artery stent, ICA lesions with stenosis less than 50%, transcarotid procedures, and procedures with a simultaneous distal cerebral intervention, CABG, or bypass. Each carotid artery was included in the analysis once, and repeat procedures were also excluded. The primary outcomes was the composite of any perioperative neurologic event, including stroke and TIA, and death, and also long-term freedom from neurologic events, death, and reintervention. And the outcomes from the total endovascular approach were compared to the outcomes of the hybrid approach. To assess for differences between the procedures while controlling for other factors, propensity scores were calculated from the listed confounding variables. We then performed a propensity score-weighted multivariable logistic regression for perioperative neurologic events and death with the procedural variable, along with degree of ICA stenosis and symptom status. Standardized differences were less than 0.1 after weighting, indicating adequate balance between the groups. And finally, Kaplan-Meier analysis was used to determine freedom from the long-term outcome for patients with long-term follow-up data. We identified 795 total endovascular procedures and 638 hybrid procedures. Mean age was similar between the groups. COPD and prior lower extremity interventions were more common in the hybrid group, while end-stage renal disease was more common in the total endovascular group. Total endovascular patients were also more likely to be on a P2Y12 inhibitor preoperatively. In terms of ASA classification, the hybrid group was more morbid, with more patients with ASA class 4 and less class 1 and 2 patients. Total endovascular procedures were more likely to be listed as urgent cases. Hybrid procedures were significantly more likely to be performed under general anesthesia, while endovascular patients were more likely to have a symptomatic lesion and an ICA stenosis greater than 70%. In terms of perioperative outcomes, the composite of neurologic events and death was similar between the two groups, occurring in 5% of the total endovascular group and 4.7% of the hybrid group. The composite of perioperative neurologic event, death, and MI was also similar between the groups. There was also no difference between perioperative stroke, death, and MI between the groups. Cranial nerve injuries did occur more often in the hybrid group, 4.1% compared to 0% of the total endovascular group. This table displays the propensity score adjusted logistic regression. As you can see, The type of procedure was not associated with perioperative neurologic event and death in the final multivariable model. Included in the time to event analysis were 556 total endovascular patients and 425 hybrid patients. This figure displays Kaplan-Meier curves for the hybrid group and the total endovascular group. 1 year freedom from neurologic events, death, and reintervention was 93% in the hybrid group and 91% in the total endovascular group. Some limitations should be acknowledged. There was minimal data available on the proximal lesion characteristics, specifically length, severity, and plaque characteristics. Furthermore, the location of the proximal lesion can be ostial, mid-common carotid artery, or diffuse throughout the common carotid artery as displayed in this figure. However, data on the specific location was not available. Also, in the endarterectomy dataset, the location of the proximal lesion was designated as either the common carotid artery or the innominate. However, in the stenting dataset, the only location that could be specified was the common carotid artery. This leaves the potential for heterogeneity between the comparative groups in this study in terms of specific location of the proximal lesion. However, if this were a case, you would expect to see a difference in the distribution of laterality between the two groups. This was not observed in this study. Therefore, it seems more likely that innominate lesions treated during total endovascular procedures are coded as common carotid artery interventions, but there's no way to confirm this. In conclusion, no clear benefit emerged in terms of short or long-term outcomes between the total endovascular and hybrid groups for tandem carotid lesions. As such, patient and lesion factors should dictate operative planning. Thank you, and I'd be happy to answer any questions.
Thank you, Dr. Decarlo, for a wonderful presentation. As we wait for some of the chat questions to come in, I have a quick question. The group there in Boston has reported over many years these ideas about these types of challenging cases. And I'm curious, compared to some of the prior reports from your institution, either from NSQIP or from institutional data, is there any significant finding that's different in the conclusions when now you're using the VQI data set?
I think the conclusions are pretty similar. I mean, I think what we expected to see is a higher rate of neurologic events and death in the total endovascular group, and that was not observed. We haven't exactly, I don't think that we've done the same analysis in like the NSQIP data and the VQI data, at least not that I'm aware of. So I think maybe a little bit has changed, but not that much.
Okay. Well, I think that always confirms then different data sets to at least get to the same hypothesis driving thought. Chris Smolak asks comments that the VQI data does not necessarily note that these hybrid procedures with retrograde common carotid stenting, whether that employs cerebral protection. And so often when you do these cases, you're putting a clamp on as your proximal or as your protection. And so how do you think that might affect the results? Because you don't necessarily know whether distal protection is used if it's not recorded in the data. Because I think it's clear those types of things are probably what is responsible for periprocedural adverse events during these types of cases.
Yeah, right. In the carotid endarterectomy data set, we don't have any information about cerebral protection. Generally, the way that we do it is to treat the proximal lesion with the clamp on the internal carotid artery. So at least in our minds, I think that gives pretty good neuroprotection and better than a spider wire and a lot of the time. So at least our thought was that that's actually better neuroprotection, having a clamp on the artery. But as you stated, we don't have any information about that in the VQI.
What's your experience? I know that your institution is very supportive of TCAR. TCAR has a role for these types of hybrid lesions, particularly if the proximal lesion is much closer to the arch.
Yeah, I mean, that's a great question. We excluded TCARs in sort of all of the last three analyses we looking at the endovascular approach because we don't know the exact lesion of these proximal lesions. So, if you have a common carotid lesion that is, diffusely present throughout the common carotid artery or very close to the bifurcation, that is, it's contraindicated to treat that by TCAR. So we excluded that. So it's a little bit tough for me to comment on that. But it's certainly possible, if you're treating like an osteal proximal lesion. So I think, in a data set where you had more information about those lesions, I think that could shed some light on that.
Maybe Mark can comment on whether you guys have done that type of case, Mark, because you've been a champion of TCAR and your institution has. If you have an osteal lesion at the left common origin, but you've got a good 5 centimeter segment to do your cut down on and a high grade bifurcation lesion, there's some technical tips if you've done that case about how to do the TCAR.
I feel like that's not a case you can do, right? Because if the origin has osteal disease, that's going to be a case that's going to be kicked out because you need the common carotid to be free of disease in order to put your sheath in for a TCAR. And I'm not sure how you would reverse it to go the other way to get into the arch. I haven't tried that, and I don't think I ever will. So I feel like these are the kind of cases where TCAR is going to not be an appropriate approach.
Okay. Another question from the audience. Philip Church asks whether in this data set, is there a cohort of endarterectomy patients that then during the, or how in the VQI did you pull these out where there's from the carotid registry, then also the retrograde common carotid lesion? I guess, is it specifically in there to know this is a clean data set?
Yeah, there's a variable that, there's a set of variables in the endarterectomy data set that talks about like concurrent procedures. So like there's, a cabbage variable, and one of those variables is retrograde proximal endovascular intervention. It's a binary variable, so all you know is that they had some sort of proximal endovascular intervention, whereas I think it's still pretty binary in the total endovascular group, but it's, I think you get a little bit more data, but not much. So I think it's a pretty,
and then maybe just as a technical tip, the cases that you've been involved with, Dr. Decarlo, and maybe Mark can also comment. Self-expanding stent, balloon expandable stent, covered stent when you do your proximal?
I think at least definitely for osteal lesions, we prefer a balloon expandable stent. And I think covered versus uncovered is somewhat attending dependent. I don't know. What are your thoughts, Dr. Conrad?
Yeah, I definitely believe in balloon expandables down there. I think the self-expanding stents tend to not take the trauma from the heart, and they'll break over time. We've seen that. I actually now favor covered stents in this area because I think they do have a better response to the motion of the heart up in the arch, and I think we get a better response from that. But again, it's anecdotal because the numbers are not large here.
Great. Okay, awesome discussion.